Hello, I'm Dr. Richard Krasuski from Duke University Medical Center. I'm here with my esteemed colleagues, Dr. Paul Forfia from Temple University Medical Center and Dr. Rajan Sagar from UCLA Medical Center. So we're talking about the patient with advanced pulmonary arterial hypertension who's quite ill, and at this point we've decided this patient needs to be going to transplant, and we're going to try to mechanically support them until they get their transplant. So Paul, what are our options? What type of devices, what type of therapies do we have to bridge them to get them to transplant?
So although it would seem that there would be a wide array of options to do that, and there are many forms of short-term mechanical support, applying mechanical support to a patient with advanced or end-stage PAH is very challenging. Although the right heart is failing principally on relation to the fact that the pulmonary vascular afterload is massively elevated. And so it's a right heart failure problem, but related to inexorable increases in the pulmonary vascular resistance. So the traditional forms of ventricular support, like a traditional LVAD placed in the right ventricular position or a short-term RVAD, any form of cannulation where you are cannulating the right heart and then that cannula ends up into the pulmonary circulation, we have generally found in the published experiences, they do not work because you are not bypassing the constricted pulmonary vascular bed and the patient's hypoxia and heart failure continue. So the short answer is the main method we've used for mechanical support as a short-term bridge to transplant has been venous arterial ECMO, VA ECMO. And if you bypass the lung circulation and support the patient's overall blood pressure and cardiac output, we can maintain some level of end organ function, nutritional status, and other things. And I would kick it over to Dr. Sagar for a second then and say, there are some strategies to the way that we cannulate these patients and consider their mobility and their viability for transplant in this context. Would you like to comment on that?
Yeah, I think one of the really most important things is to maintain transplantability, and most lung transplant centers have a list of criteria to maintain transplantability, and one of them is to be functional. To be able to walk a certain distance, whether it be supported with oxygen or mechanical circulatory support. They have to have no significant renal insufficiency, which often these patients are struggling with in the cardiorenal syndrome that our patients often have with PAH. And when we use mechanical circulatory support, we need to cannulate patients such to support the functional requirement. And a lot of times, so we all discuss the best way to do this. We try to avoid groin cannulation and try to do some of these upper extremity type of cannulation modes, either central cannulation or some type of sport model that's been published by the Columbia experience. And so that maintains their functionality and allows us to keep them transplantable. And in many cases, looking quite well, essentially on portable cardiopulmonary bypass.
Really, it's almost miraculous when you see some of those patients walking around cannulated like that, and the fact that they're working on building up their muscle mass instead of losing muscle mass, which I think we're also experienced in seeing in our ICU settings. So now let's say the patient has made it made it to transplant. They've gotten their transplant. What types of issues are we dealing with in that peri-transplant setting, trying to improve the outcomes as well as we can? I'm going to leave this for you, Rajan.
Well, so for all the indications that we transplant for in terms of lung transplantation, PAH, pulmonary vascular disease, is one of the harder and more difficult transplant populations. For the perioperative issues that often can occur either just before transplantation, during, and immediately after transplantation. They're particularly at risk for reperfusion injury, or what we call primary graft dysfunction, this non-cardiogenic pulmonary edema that is well appreciated after lung transplantation and even after endarterectomy, for instance, in CTEPH patients. This is a form of lung injury which we support. It requires supportive care, either prolonged mechanical ventilation, diuresis. There's no particular therapy in terms of a medication per se, It's a supportive mode, essentially. But these patients are particularly at risk for that, given their conditioned, with their RVs, which are, of course, albeit failing prior to transplantation, but after transplantation with a normal pulmonary vascular resistance, quite impressive in terms of their contractility and the cardiac outputs they can generate, leading to this increased risk for lung injury. So once we support that, the other things that we sometimes see, especially in our older transplant recipients, is the concept of unmasking, if you will, a stiff left ventricle or a stiff left atrium, where these patients actually can develop pulmonary edema, cardiogenic pulmonary edema, once you actually give them a normal pulmonary vascular resistance. So they're essentially masquerading with severe pulmonary hypertension, and then we unmask yet a second disease, if you will, after transplantation. Again, mostly in our older recipients.
Thank you, gentlemen. That was a wonderful discussion. I think we heard a lot about some of the options we've got, albeit they're not particularly great, but we've got some options for bridging support. There's some neat techniques of cannulation. Thank you for bringing that up. And we now know that patients not always out of the water immediately, when they end up with their transplant. So it's very important to have that very close follow-up and look for those types of complications afterwards to be able to get them out of the hospital. Gentlemen, thank you so much for your discussion. Really appreciate it.